Hello, today we are breaking down the critical, practice-changing updates to the 2006 guidelines for acute ischemic stroke. These are the kinds of changes that will directly impact our clinical decision-making from the ambulance to post-procedure care.
Welcome to the Dr. Make Explainer series. We're here to distill exactly what these new guidelines mean for your clinical practice. And before we begin, our standard disclaimer. This content is for educational and informational purposes only. It should never replace your own clinical judgment. Our entire analysis is based on the new 2026 AHA/ASA guidelines. So here's our plan. We'll look at the big shifts in thrombolytics, then the new expanded criteria for endovascular therapy. We'll also cover crucial updates in post-procedure care and special populations, and we'll finish with the absolute key takeaways.
So let's get started with a high-level look at these recommendations, which really do represent a major evolution in how we manage acute stroke.
First up, thrombolytic therapy. There's some really significant shifts here regarding our drug of choice, how we handle minor strokes, and the absolute urgency of treatment. This is a big one. For years, alteplase was the undisputed standard. Now, the 2026 guidelines elevate tenecteplase at the 0.25 mg per kilogram dose to a Class 1 recommendation, putting it on equal footing. This means we now have two first-line options, which could really change hospital protocols.
Now this brings us to a common clinical crossroads. What do we do with those minor, non-disabling strokes? This has always been something of a gray area.
Well, the new guideline gives us a very clear answer. For these patients, intravenous thrombolysis is now explicitly not recommended. The preferred approach is dual antiplatelet therapy, or DAPT. This is a huge shift, telling us to focus less on a raw NIHSS score and more on the crucial clinical question: is the deficit truly disabling?
The guidelines also reinforce the message of urgency. If your patient is a candidate for IVT within that 4.5-hour window, the directive is simple: treat immediately. Do not wait for advanced imaging like a CTA or perfusion scan.
Okay, let's switch gears and talk about endovascular treatment. The eligibility here is expanding, especially for patients with large core infarcts and basilar artery occlusions.
This truly is a paradigm shift. In the past, patients with large core strokes, meaning an aspect score between 0 and 5, were pretty much excluded from thrombectomy. The 2026 guidelines now say EVT is reasonable in select patients in this group. This opens a critical therapeutic door that was previously closed.
And for basilar artery occlusions, the recommendation is much stronger. EVT within 24 hours is now a Class 1 recommendation. But, and this is key, only for patients who meet specific criteria: an NIHSS score of 10 or higher, and a posterior circulation aspects, or PC aspects, of 6 or greater.
You're watching the Dr. Mech Explainer series. Let's now move on to what happens after the procedure and to some important special populations.
This next section covers key updates for post-IVT care, looking at blood pressure and glucose, and also the introduction of the first ever formal guidance for pediatric stroke.
Let's talk about blood pressure after thrombectomy. Our old target was simply less than 180/105. The new guidelines now add a very important warning: do not get too aggressive. They specifically state that lowering the systolic blood pressure below 140 is actually harmful.
And we see a similar theme with glucose management. That very tight glycemic control, where we might have aimed for a range of 80 to 130, is now explicitly not recommended after a stroke.
Now, this is a landmark development. The 2026 guidelines introduced the first ever formal recommendations for both IVT and EVT in pediatric stroke patients. This finally provides guidance in an area where we had very little before.
Okay, we've covered a lot of new information. Let's distill this down to a summary of the most critical changes you need to remember for your practice.
All right, let's lock in these key points. 1. Tenecteplase is now an equal first-line option to alteplase. 2. Your focus should be on disabling deficits, not just the NIHSS score. Minor, non-disabling strokes get DAPT. 3. Patients with large ischemic cores are now potential candidates for EVT. 4. EVT for basilar artery occlusion is Class 1 for select patients within 24 hours. And for post-procedure care, avoid dropping systolic BP below 140 and avoid tight glucose control. And finally, we now have formal guidelines for pediatric stroke.
Thank you for joining us for this Dr. Mac Explainer. We hope this has been a valuable update for your practice.
To help you with a quick review or even for exam prep, we've created a comparison sheet that summarizes these changes. The download link is right there in the description.
Please subscribe and hit the bell for notifications so you don't miss future explainers on critical updates in medicine. Thank you for your time.